Good morning, co-chairs.
Good morning.
Okay, I show 9 o'clock. Ready when you are.
Yes, trying to just organize my windows in a way that makes sense. And then of course I lost the mute button for a brief moment. Thank you very much. Yes, good morning, everyone. Thank you all for being here. My name is Emily Cronin. I'm the Direct Care or Labor Co-Chair of the MLAC Subcommittee for Access to Care. I am joined by Kim, my Management Co-Chair. We have a pretty jam-packed agenda today, so I'm going to move right into it if that is all right with everyone else. Kim, is that okay with you? Okay, so we have a quick 5 minutes to summarize the concerns that we have heard over the last 3.5 months. Is it possible, Terry, to place that spreadsheet on the screen?
Yes. Baba said yes. just give her a minute because we have, like you said, we have several screens.
Yes. And I want to let stakeholders and attendees know this document, Terry, is it already on the website?
It is on the website, and it is updated with the latest proposals as of 3 o'clock yesterday afternoon. So if you look on the website, you should be able to find I believe it says Access to Care table is what it's called, and it's an Excel document.
Great. I do not expect in this meeting today that we're going to cover all of this, right? I'm going to summarize it. The intention, we'll talk about next steps after the presentations, but the intention is to give stakeholders time to review this document and provide additional feedback for those who haven't had a chance to do so. So please understand that I'm not going to, like, in 5 minutes read this whole thing and expect you to retain that information. Essentially, what we had attempted to do over the course of this time meeting, trying to summarize the things that we've heard that have either become clear that they're trends or very specific instances that we think we can really make some suggestions upon improving the system in either small ways or big ways. And we identified several key issues. I know the name of our subcommittee is Access to Care, so obviously we found some significant issues related specifically to access of care. Providers throughout the course of our meetings sort of identified a consistent lack of timely access. So timeliness is a big component that we discovered, and many of the issues that we have outlined in the table sort of address timeliness in one way or another. We also looked at provider availability. Those of you who are here, it is no surprise that we have had reports and are aware of provider shortages. We kind of talked a little bit about providers shortages related to being willing and able to treat worker compensation cases, potentially providers being unevenly distributed amongst the state and also between MCOs and outside of MCOs. And then we identified that there's some antiquated and or ineffective coordination or communication, which has really sort of limited providers wanting to participate in the system. We heard significant additional issues related to communication as it relates to sort of pre-auth processes. We have some antiquated and unnecessary delays in the way things are being communicated between the injured worker, the insurer, the provider, and other people involved in the case. Some of that having to do with things like mail, something as simple as the way that pre-auths and communication is done between those involved in the system. We have heard about some delays in response times from insurers and third party that may cause treatment delays. We noted that there may be some lack of enforcement mechanisms or just some additional education that needs to be provided on what the expectations are to meet the needs of the injured workers in the system. We also heard a little bit about restrictive or difficult to navigate systems within MCO, and then a little bit of variability between MCO and not MCO, which kind of contributes to some uneven or unequitable access. And then, of course, significant education and certification gaps around billing processes, communication processes. This was, I think, a really big eye-opener for me because a lot of the education, it sounds like, was directed to the providers themselves. And if you work in a system in a provider's office, it's often those who are not the provider themselves that do a lot of the billing and coordination and administrative follow-up. And so maybe there's the potential to broaden the education to incorporate those roles. And then it takes a little bit less responsibility for the provider to participate in some of this education. And just in general, some hassle factors that I think have been brought up in the past, sort of resurfacing during these conversations. Kim, do you have anything to add?
I do not. Emily, you did an excellent job of summarizing all of that. Thank you.
And again, I didn't touch on everything in the table. I'm just trying to make sure that I'm respectful of the time. And again, we are hoping to get some additional feedback and some additional conversations outside of this meeting around some of the things that we've heard and some of the suggestions that we might make. Anybody have any questions before I move to some of the proposals from our stakeholders? Tremendous, I'm right on schedule. Next on the agenda, we have a proposal from Oatlo.
Hi, thank you, co-chairs. Keith Simple with Oregon Trial Lawyers Association. We presented a written proposal. I'm sorry that it's coming in late, but our position has always been that we wanted to hear from the providers first and start with their needs and their concerns about the system. And we've heard from a lot of providers. We summarize what we think we heard from providers, which was a big part of this is moving care forward and being able to get the authorizations that they need to do that. We think that a more formal process for submitting requests for pre-authorization and responding to those requests could be established through rulemaking. And we have actually an advisory committee that is seeking input as we speak, that the Workers' Comp Division has set up to look at medical rules and managed care rules. So these discussions and ideas and proposals are timely and will probably be submitted in that context as well. But we've, in the Oregon Trial Lawyers Association, have called for a more formal process with deadlines, conclusive evidence that these things have been submitted, a written paper trail that would be created through a formalized process so that we can move these issues through to adjudication. There's no getting around the fact that we're going to have disputes in the workers' comp system over approval of treatment, but there needs to be a process to make that fast and make it easier for the worker, the doctor, the employer, the insurer, everybody to have these disputes adjudicated. We've asked that the department maybe develop more formal procedures that mirror those that we see over at the Workers' Comp Board for litigating all of the other issues relating to claims benefits. We would like to see a little bit more of the standard procedure for litigation, presentation of evidence, rebuttal to evidence, those types of things. With that, not overly compressed timelines, but some timelines. Right now, those timelines are completely lacking. There is not a standardized system. There's not even a requirement to respond to pre-authorization requests in some categories. And the doctors are sitting there befuddled, not able to move that forward. So we think that would be a great thing. And then if there's not a response, then an appeal could be filed by the worker so that the delay doesn't just go on and on. We'd also like to see providers be paid more. The providers we heard from estimated that workers' comp claims add 20% to their overhead. Maybe the idea of the pre-authorization helps with that. But it seems to us that, this problem is a long time in the making, and we've got a lot of trust to restore with the medical community that they can operate in the workers' comp system and deal with the overhead that requires. There's various ways of doing that. We'd love to be part of that discussion, but we think that that's a really important key part of this. We would like to see expanded access for the PAs and other nurse practitioners, other providers who are now currently constrained by the rules. But we would like to see that coupled with strengthened requirements for workers to be able to get equivalent second opinions when they're in litigation. We have a worker requested medical exam process that allows the worker to get a response from an expert with similar qualifications to an insurer's IME. We definitely need that. No offense at all to nurse practitioners, PAs. They have plenty of medical education, but I've got to imagine it's hard for them to respond to the assertions of a medical specialist who's got years of board certifications and things like that. Workers need access to that. And if there is a push towards opening access, we would like to see those two things coupled. We've really appreciated being part of this. I would love to see, Ola would love to see, I personally would love to see these discussions continue. I would love to see an open door for providers to discuss not only, MAC discusses developments in technology, and should we open up these formally experimental procedures. I would love to see a big focus of MLAC and MAC be, what can we do to bring providers back in, especially these large healthcare networks. I just talked to a client, Peace Health said their policy is no injured workers, so go see occupational health. That so severely limits. I don't know if they're movable on that, but that is just such a critical piece. And I think that outreach could be done with no statutory change or administrative rulemaking. If it can be done by an MCO, it could be done by an MCO as we speak or in the near future. So that's what we have from OTLA. Happy to take any questions, happy to be part of this discussion in the future.
I was just giving the 30 seconds of uncomfortable pause to see if there were any questions before I moved. I didn't want to cut anyone off from trying to find the raise the hand button. Kim, do you have any questions on there?
I don't, but I just want to make sure, was the document, is that going to be uploaded onto the website so that everyone can have a chance to, read that, all of the things that Keith just went over? Is that that's on the website?
It's on the website now. Yes.
Perfect. Okay.
We tried to distribute it to key stakeholders that we've been in prior discussions with yesterday to give folks a heads up that we weren't, trying to step in with this at the last minute with no chance for them to digest it.
Thank you. I appreciate that. There are no questions, so we're going to move to our next proposal presenter, Dr. Sabo.
Actually, it's Lon, Emily. Did you see that? Lon is on the cell phone. I apologize.
I don't have the most updated one that I pulled. I pulled it this morning at 5 a.m. and then we've gotten an updated one. I'm so sorry, Lon. Lon's first, then Dr. Sabo. Apologies. Yes. I'll find the right but most updated one right now.
Okay. Good morning. This is Lon Holston down in sunny Southern Oregon in Medford. I recently put together a document and sent it to the committee for their consideration. I took somewhat of a different tact when we were looking at providers and what they were doing within the workers' compensation system, but also in the private sector, because certain aggravations that they go through in the private sector bleed across into the workers' compensation sector. And I started out in the document looking at doctors and what made them actually just leave the profession, and all medical providers leaving the profession, whether it's nurse practitioners, or physician assistants, etc. What I found was, and I put in the document, there was a serious life balance problem for the medical providers. They spend so much time and effort trying to treat patients, whether it's a workers' comp patient or whether it's in private practice, that their time at home is severely limited. Then I looked at the life of a physician and how long they would stay working, so to speak. I went through and used some of the documentations that was presented to us earlier from the department that talked about workers' compensation, the number of providers, who's actually providing care, whether it's our good friends, the chiropractors or physician assistants, nurse practitioners or physicians. What I found was in this process is that we have a certain number of physicians and medical providers that are actually treating in the comp system. And I got to thinking, well, how do we retain these folks and stop the bleed? Now, there's a certain amount of stuff that the committee has taken a look at, and certainly that helps, but we have not looked at some of the other hassle factors that are inherited with their profession. So I kind of walked through the document with some of those and talked about maybe we needed to create some kind of retention for workers' compensation medical providers. Now, my approach, of course, has a lot of assumptions to it because the numbers I got from the department documents are probably the most accurate that I could find anywhere else. And so I thought, well, maybe we could set up a second type of retirement system for those medical providers based on the number of injured workers that they see in their profession and in their practice for, let's say, their career, which could be 20 years, could be 25 years, depending upon whatever the physician would like. So I ran those numbers up and said, okay, so how would we do it with a minimum amount of headache and hassle for the department to administer this? Well, we do have the Workers' Benefit Fund, and you do have a department set up to manage it. So it wouldn't be too much of a stretch to say if we provided some kind of retirement program as an incentive to the medical providers to stay in the system and treat these injured workers and bring them back to medically stationary and get them back to work might be beneficial. So I looked and said, gee, how much would this actually cost the system, or what would it cost for the workers or the employers? Because I based this model on the Workers' Benefit Fund in the sense that if you took 1/8 of a cent per hour from a worker and 1/8 of a cent per hour from an employer, you could generate enough money to start a retirement system based on the number of injured workers seen by the medical provider. So we had Dr. Bowman testify, and he said, gee whiz, he had about 70% of his practice was injured workers. I kind of used that as a baseline that said, okay, well, that's quite an amount of injured workers he's seeing. So the reward for that in a retirement system should be greater than those who only have, let's say, 25% of their practice being injured workers. And I put some stuff together for the committee to take a look at. Now, I know there's something in this for everybody to hate. I've talked to some of the other folks out in the community who said, yeah, that's a long shot, or, oh, yeah, the employers are not going to like it, or the insurers are not going to like it. Now, I get that. But if we don't start coming together here in some ways and get creative, we're going to be going back and we're going to be placing a lot of emphasis on the mechanics of trying to make it better for the physicians in the fields. And yes, that needs to be done. But my whole document was a concept proposal that I would love to see some folks get together, take a look at it, knock the edges off of it, and maybe come back and present that to MLAC or the Access to Care Committee with something that's a little more solid. So I'm open to any questions that anybody may have out there, but that's kind of a brief summary, and I'm not going to read the document for you. I know you guys have probably been over it. Can anybody hear me?
Yes.
Yes.
I was given that same brief moment to see if any hands were raised or if
Okay.
anybody came off mute.
Yeah.
I realized you're on your phone so that you didn't see me do that awkward stare at the camera waiting for somebody to respond.
Yeah, I'm actually in a car trying to do this in a parking lot.
Well, I do appreciate your time and the comprehensive proposal that you offered, including great math, which was easy for me to follow, and I do appreciate that. Some of the numericals from my perspective are a little sort of cerebral. Still kind of understanding some of how the fiscal is attached to some of these things. So I do appreciate that. It does not look to me like we have any stakeholder questions. Kim, do you have any questions?
I don't, but Lon, I just want to thank you though for putting that idea out there, because that's how things start. You know, they kind of germinate from this idea, and then someone's brave enough to put that idea out there, and then I gotta tell you, it's got my wheels turning. And just to share with you, when we were up at Bend for the reception, with the tagging on with the conference that was up there, one of the conference attendee approached me at the end of the reception, and he kind of had an idea similar to yours, but it had to do with setting aside money for injured workers' retirement fund. And I just thought, gosh, it's so interesting. Both of you were kind of had this idea about putting money aside for retirement. You know, yours is more for the providers. But anyway, so I just want to thank you. I think, you know, it's a good idea, you know, that's, you know, it would be nice to, you know, kind of keep working through it.
Okay, thank you very much. I appreciate it.
Co-chairs, I want to let people know, Lon's proposal is on the 9/12 meeting. It's not on today's meeting on the average weekly wage website. Or, excuse me, I'm sorry, Access to Care website.
I was like, really?
I'm getting my subcommittees confused. Sorry.
Yes, many subcommittees, sorry. Both start with A. All right, I think I have the correct agenda now. So I do think, Dr. Sabo, it is your turn now.
Thank you. So you can hear me, correct?
Yes.
Yes, sir.
So yeah, my proposal, I won't take much of the subcommittee time. Essentially what our proposal is to adopt SAFE's proposal, whose centerpiece is forming their own MCO, and some of the other stipulations that Evo presented on September 11th regarding the city of Portland, self-insured and other insurers, and then also their claims processing being separate from coordination of care. We don't have any issues with that. But then calling for the removal of time limitations to serve as attending physicians, removing the time limitations from chiropractic physicians and naturopathic physicians, in addition to physicians associates and nurse practitioners. And the other piece relative to the MCO is when they first started, I think the MCO in this area, Albany, Corvallis, Lebanon, Sweet Home, was Health Futures. We all met at Lynn Benton Community College, and it was all the MCOs were open, meaning any willing provider that was willing to follow the rules and the care pass pre-authorization mechanisms were allowed on panel. I mean, why at this point, why would you restrict them? So ours calls for opening the panels. Currently they're closed. And as you've seen with prior testimony, many of those provider lists are not very accurate as far as who actually takes workers' claims. And then relative to loan forgiveness, including students wishing to pursue careers in chiropractic, naturopathy, osteopathy, named specifically, and nursing and medicine. So that's basically what our draft proposal is.
Okay, that's the right amount of time to see if any hands get raised. I don't see any stakeholder questions. Just want to double check with you, Kim. Do you have any questions for the table this time? Oh, I saw a hand. Where'd it go?
Do you see?
No, it was there for a brief moment, I promise.
It was here. It's Steve Bennett here. I'm sorry. I'm sorry. I'm not good at technology at all. Anyway, my only question is, where do we have? I'm interested in the open panel, closed panel. Is your proposal anywhere? Because I mean, I have some concerns about that, but I just want to know if I can. I haven't been able to review it yet, so I just want to know if there is a proposal we can see on the website.
Was that a question directed at me?
Yeah, I'm sorry. I want to make sure. Are you asking
Well,
where?
I'm asking the committee or whatever. Is there an actual proposal, or is he?
Yes, Gary, Dr. Sabo's proposal letter is on the website for today's meeting. Is that correct?
Yes, it is. Steve, are you asking if there's a legislative concept? Is that what you're asking?
I'm saying other than just the statement that he wants an, which is an open panel. I mean, is there actual proposal draft either legislatively or regulatory or any information? Is there any information I can look at? Because I mean, I have concerns about, I think there's a reason there's closed panels now, because there's a necessity that the people be good, be qualified to work injury cases, and so that we can get the worker back efficiently and with the best care possible. So I would have an issue with open panels, but I mean, I'd like to see if there's any proposal or rationale for it. I just want to see what materials are out there, but I would say I have some concerns about open panels.
Can I ask a question? So your concerns was relative to adequate training of the provider?
Well, not so much training, but I would want the best doctors to treat the workers.
How would you determine who's the better doctors? I mean, how is that determined? How
So
do you?
Dr. Sabo, can I interrupt for a second? Dr. Sabo, you did put in a legislative concept, is that correct?
Yes, concepts in LLC.
Okay, so Steve, maybe when we have that language, that would be a better time to.
Oh, no, I agree. That's all I'm asking, is to be able to see it.
Yeah.
Thank
Okay.
you. So will someone send that out? That's all I'm saying. Where will it be posted, or how will I receive it?
When Dr. Sabo gets it, he would send it to me and I would post it on the website then.
Thank you very much. Thank you.
You're welcome.
Thank you, all of you.
Okay, thank you. Thank you, Steve. Thank you, Dr. Sabo.
Thank you, Dr. Sabo. Kim, did you have any? I think I asked you. I just want to double check that I don't. Okay. All this agenda, I try to be as efficient and also tangential as possible at the same time. It's a fun time. All right, next on our agenda, I have Ivo with SAFE. Ivo, are you ready?
I am ready. I'm just hoping, Baba, if you could bring up the presentation, and Elaine and I will tag team today. I'll get us started and then hand it over to her. Co-chairs, again, for the record, Ivo Trummer, Government Relations Director for SAFE. Thank you, Baba. Appreciate the opportunity again to be in front of you, and we really appreciate your work here for months now to kind of dig into this issue. We were asked again to kind of present on what drove our legislative proposal from the last session and where we are today. I will start with that, and I think we will end with that, right? We still have the same kind of goal in mind, right? We want to ensure that there's resilience in the MCO's system, that workers have access to timely access to quality care, and that we keep employer rates affordable for Oregon's employers. What I thought, though, I want to get us started on is sort of tell a story of what happens in Smahonia. Bob, if you can move to the next slide here. And we'll do this fairly quick. We looked at 1990, Mahonia, the special session that implemented the Mahonia Hall reform and created today's system, right? It was in 1990. No surprise there, right? Google tells me Oregon's population in 1990 was about 2.8 million. It's 4.2 or 4.3 million, depending on how you round up or down today. So no surprise, the number of subject employers has almost doubled over the time. Next slide, please, Baba. Similarly, the number of subject workers has relatively continuously grown. You see the 2008 recession in there, and and COVID, obviously, sort of the dips. But generally speaking, more workers in the system. However, and if you go to the next slide, Baba, really this tells a story about the Mahonia Hall reform, and I think the big success that it was the focus on safety, right? If you look at the number of accepted disabling claims still in 1990, and I kind of see that trend line right there. It's not in one straight line, but sort of the trending down tells a good story about, right, the implementation of safety and the focus on safety. Now, this is frequency. This says nothing about severity, and I want to spend a moment here to kind of tell a different story too. This does not say we need less people that we see less people being treated on a year-over-year basis, right? The big difference that workers' comp insurance has, or what differentiates workers' comp insurance from many other lines of insurance, or most other lines of insurance, is the long tail, right? We wouldn't be treating, right, if whatever slice here of the 2024 disabling claims would be saved. So we wouldn't just be treating those people in 2024, but there are people that we are treating from the year before, the decade before. In fact, we still have claims from the 40s, the 50s, the 60s, the 70s, the 80s, the 90s, the early 2000s, and the 2010s that we are treating. And some of them, not all of them, still require medical care. So the number of people that access the medical treatment in work comp does not necessarily go down, even if the number of people that get injured goes down or severely injured goes down. If we could get going, we'll skip that one. I want to ground us again on sort of what drove our proposal. MCO resiliency, you see 1990, we are back to where we were in 1993 MCOs. In the heydays, right, the mid-90s, there were 13, if I'm reading the chart correctly here on the left, and you see sort of the reduction. In fact, the last 10 years or more in the past, we had 4, but we're now down to 3 that will work very well with, but we clearly see sort of a problem if that number reduces further. The next couple of slides, I just want to show, thank you. This is still the old slide, and this is my fault. The person I needed was already out when I updated this yesterday, so that is on me. I don't have 2024 numbers, but the story, right, the access to care, the median days to first, and this is the median days to first physical medicine visit for an injured worker, right? 12 days in 2013, 22 days in 2023. It takes longer, which creates a problem for the worker who has to wait longer, and it might create a problem for sort of for the employer in the long run. This might mean more time loss needs to be paid, the claim gets more expensive, the premium rate goes up, and it becomes less affordable. The next slide, please, is we have talked about this, medical escalation, the claims cost, the medical part of our claims cost just keeps rising and increasing year over year, which brings us to our proposal that we had last time. I think, Elaine, this is where you take over.
Yes, hi, Elaine Schooler, Assistant General Counsel for SAFE. We wanted to sort of revisit what we had previously proposed during the legislative session, and also some of the feedback that we've received and how we've incorporated that into our proposal to continuously improve it in response to issues that have been raised. And some of those issues were a common theme throughout the subcommittee meetings that we heard from providers. The ability to attract providers into the system, how can we entice them to step into what can be a complicated process with different layers and interests at play when there are employers looking for work releases, insurers who may need follow-up answers as to treatment plans, those work authorizations so they can make their timely time loss payments, and then track the workers' recovery as they go through the medical process of getting better. And then layered on top of that are managed care organizations that do play a critical role in ensuring that workers are receiving appropriate, reasonable, and timely care that is tied to best practices and medical standards, so that medical journey is as smooth as possible and as successful as possible for those injured workers to help them recover and take off some of the uncertainty or stress that may follow from having to find a provider on their own when there's no central resource or opportunity to seek out providers who will accept workers' compensation absent perhaps a Google search or reaching out to friends or family who may have gone through the process and could be a resource. One of the pieces that we're interested in exploring is loan forgiveness as a way to entice medical providers to enter the system from the get-go. And that really couples with removing some administrative barriers. We heard from several providers the importance of having informed and skilled office staff, in particular the nurse practitioner who's since retired, really explained how valuable that was when she transitioned into the workers' compensation space. Not only that, but also having a mentor through another practitioner who was already providing care under workers' compensation. Those were very valuable experiences in her transition and journey throughout and made it more seamless. When we think about those administrative barriers and how to lower them, Safe Corporation does have some efficiencies there. We have our own medical billing and audit department. We have those individuals who are specialized in that language and in those processes who could provide some assistance, provide training to those medical providers and their office staff to give them a leg up and smooth that transition into workers' compensation, make it more seamless, and reduce those administrative barriers. We're also looking at the benefit of managed care organizations within the workers' compensation space. We saw the benefits of the Mahonia Hall reforms and that large influx of managed care organizations after the changes in the 1990s. But we've seen a steady decline in that, and that's an opportunity that SAFE is looking to participate in, whether it's partnering with another managed care organization or creating a SAFE-owned subsidiary that could really build in some resilience into the space. We saw with the departure of Caremark when they ceased operations, that really created a system where we were left with 3 managed care organizations, 2 of which are tied to current health systems, 1 is not. And SAFE had several hundreds of claims enrolled in Caremark that were unable to be transitioned to other MCOs due to capacity limitations. And that really brought the lack of access to the MCO process to the forefront for SAFE Corporation. And we haven't seen other companies moving into that space. And that's a concern, that we need some resiliency there. We need to ensure that the benefits of the managed care system remain in place and carry over into the future. And SAFE is here to support that. Next slide, please. Okay. Also included in our proposal was a firewall between SAFE, the insurer, and a SAFE partnered or SAFE owned managed care organization. That's to create a sufficient separation between the 2 buckets that are required for decisions on medical services. A managed care organization is responsible for reviewing whether those medical services are reasonable and appropriate for the worker. It's not making the determination as to whether or not those services are compensable. and related to the accepted claim. That lies with the insurer. And that's true whether it's our current system where Safe Corporation acts as the insurer and contracts with a managed care organization, or under Safe's proposal, if Safe partnered with or had its own subsidiary. And we want to make sure that separation is very clear to stakeholders. Ensuring that separation, we would have a audit done by the Workers' Compensation Division. That audit would be subject, well, that audit process, excuse me, would be subject to rulemaking by the Workers' Compensation Division to make sure it's administered in a consistent way that's also transparent. And would also happen on an annual basis, with Safe bearing the cost of that audit. The subsidiary too, if the managed care organization were formed under that umbrella, would also have a separate board of directors, also appointed by the governor, to ensure that independence and that separation. And we're also open, excuse me, to discussing additional safeguards with stakeholders. You'll see later on our contact information is available here on the slides, and we're willing to have those conversations with any interested parties. Next slide, please. Okay, so some of the things that we've also heard is that we need more providers. And we've seen in the workers' compensation data, the actions taken by nurse practitioners and physician associates to fill a gap that's been created by declining numbers of medical doctors participating in the system. We would be supportive of including full attending status to nurse practitioners and physician associates. We see that they're already taking on this greater role, and they have the ability to do the things that many of our medical doctors are doing. They're making referrals to specialists, requesting imaging, prescribing medication, and sending workers to needed therapies, whether that's physical, occupational, or maybe mental health treatment, depending on the individual worker's needs. We also did extensive outreach over the last several months, and we heard that there was some confusion about our proposal. And so we're looking to clarify that a Safe MCO would be open to all insurers. That includes the self-insureds, private insureds, and the city of Portland in the state of Oregon. It would not be exclusive to Safe. Any insurer or self-insured could contract with a Safe MCO. In addition, it would also require a Safe insurer to utilize more than one managed care organization. And there would also have to be built in some reasonable standards for review if a contract wasn't able to be formed, with a review by the director to ensure that this is a compliant process, and also the intent, which is to build resiliency in this space and support the managed care system as a whole. Our goals at the start of this process, which, gosh, feels like 2 years ago now, still remain the same. We want to ensure the managed care system has resiliency, has longevity. We want to guarantee that workers are getting timely access to quality care. We want to make sure that rates remain affordable for Oregon employers in the long run. Next slide, please. So here is our contact information. We're happy to continue engagement with stakeholders and discuss our proposal, other ways to improve upon it, and we look forward to those discussions. Thank you.
I have a question.
Go ahead, Lon.
Okay, Lon Holston here. Hey, I appreciate this new concept that Safe has brought forward. I haven't been able to read it, nor have I seen a LC draft of this, but I did have a question regarding the student loan forgiveness. Either Elaine or Evo, I don't care who answers this. What would be your proposed funding mechanism to for the loan forgiveness for medical providers?
Not the worker benefit fund, which I think you had in mind for, which you had in mind. We would figure out what funds we would have available, to do this. I think is the plan.
So funds available, does that mean Safe Corporation paying for it? Or do we have a new proposal with funding mechanism that makes that happen?
Yeah, we have not thought, so our proposal is not a system-wide, it would just enable us, I think, to do this. Yes.
Okay,
Which granted lawn, right? We are a large part of the system, but we are not by all means the entire system. So it would have a limited impact in that sense.
okay. Thank you very much. I appreciate it.
Mhm.
Mr. Bennett.
Thank you. I'm trying to get my video to work, and there we go. I work with, I represent American Property Casualty Insurance Association, which represents the private insurance market. I think the SAFE proposal is sort of a dangerous proposal. We are in favor of an efficient medical system, and we want to have good access. And, I've listened to proposals by the Trial Association, Keith Semple. Often I am at odds with what he says, but I think a lot of what he says was very good. Understand that maybe changes, reforms need to be made. I thought some of the other proposals were at least interesting with the retirement funds. I stated before, I'm not totally on board with open panels, any willing provider, but I certainly can understand that and discuss it. As I said, I'd like to see the proposal, but APCIA would love to see an improved medical system in Oregon where it's efficient and workers get the care they need in an efficient, quick process and return to work at an appropriate time. I think the SAFE proposal is dangerous because it would only help one part of the market, which is the SAFE market. SAFE already, first off, it's a quasi-state-run entity. APCIA, as a general rule, is against any type of state-run entity competing against the private market. We would say they only exist when a work comp system is in crisis, which I positively Oregon is not in crisis, but SAFE already enjoys a whole lot of advantages against the private market regarding regulations, regarding having the government appoint their board, regarding very favorable tax treatment. They do not exist. They are not the market of last resort as a lot of state funds are. They participate as the other private insurers do. SAFE does have a whole lot of advantages. I think we can all agree on that. SAFE runs more than half the market. Now, all of my members, the private insurers, are not permitted to run health services. So I have a real problem with now allowing SAFE to be allowed to provide medical services when other insurers cannot. So what I would like is a level playing field between our private insurer members and SAFE. And what I would also like is that this subcommittee come out with solutions that will help all employers and all workers, not just those who are insured by SAFE or who go to SAFE. But to me, this will hurt both the self-insured market and the private insurers market and benefit SAFE mostly, which overall will be bad for the Oregon work comp system. Thank you.
Well, thanks, Steve. First time we've been called dangerous that I can remember, but I'm not sure if that's a compliment or not. Again, I will reiterate what my colleague Elaine said. This SAFE MCO should the MLAC and then eventually the legislature agree to that proposal, will be open to all insurers, self-insured or private insurers, to utilize the be a firewall there. We are not a quasi-state entity. We are a state entity. Appreciate it. We agree with you, right, that there should be, we are looking for an Oregon system where all healthcare is delivered in an effective and equitable way to injured workers. So I think we all look for that improvement. We believe that our solution is a good one. Steve, I understand that you're worried about market share and competition, which puzzles me because we are talking about access to care, but we'll leave it at that. Thank you.
If I can respond, I was just meant to stop first because sometimes when I just say it's a state-run entity, then they get mad but I understand your point and I agree with that. Access to care is important and I would like that for all people, whether they're self-insured, private insurers, but to say that you do not want a level playing field where you can participate as a medical service while private insurers are statutorily restricted from doing that. That's the problem we have. If it's not good for private insurers, it should not be equal for people who are competing against private insurers.
Steve, I'll repeat what I have said in other form over and over again, right? If the private insurers want to be part of this, I look for you bringing an amendment. I have yet to hear that you want to be part of this proposal. And my job is to represent SAFE, so.
I may build off of that and just reiterate as well that the SAFE MCO or SAFE partnership with another MCO, that is separate from the SAFE the insurer. That would be a separate entity. So the competitive advantage is maybe not as strong as the suggestion from Mr. Bennett, because really that MCO is its own separate entity with its own board of directors who are appointed by the governor, a firewall with an audit by the Workers' Compensation Division, which is something that does not exist for the other 3 managed care organizations in the state. This would be a more regulated, more oversight managed care organization than we currently have. And we feel that that's important to ensure that it is an MCO that is living up to the standards that were set forth of providing quality care to injured workers that's appropriate and reasonable, and ensuring that there is an adequate supply of medical providers to treat those injured workers who may have challenges accessing care on their own.
Thank you. Keith?
Hi, Keith Simple, Oregon Trial Lawyers Association. I just wanted to weigh in. We haven't really spoken a lot to the MCO concept, but the trial lawyers do want to make our position and thoughts clear on that. When I look at the graph about delays in care, what I see is a major jump after the pandemic. And I think every single person on this call has experienced that in the health system, that it has been in disarray. I think that that's largely true across the board. So I just wanted to make that observation about that statistic, that may mirror fairly closely what is happening just in the health system in general. Like I said earlier, our position has always been that we'd like to start with the doctors and what they're asking for and what they would like to see. In sitting through and participating in every single one of these meetings, I didn't hear any of the providers saying we really need more MCOs, more guidance from MCOs, more support from MCOs. We see that there's been a decline in the number of MCOs, and that could mean one of two things. It could mean that more legislation is needed to decrease the barriers of having more MCOs, or it could mean that the MCO model just isn't working great. It seemed from the providers that they were pretty clear that it adds another layer of discussion and correspondence beyond what is normally associated with insurance and non-MCO workers' comp. Some said directly that they thought that this was a bad idea. There are things that the provider said would be helpful, and we would like to keep the focus on those discussions. And frankly, maybe we need to take a hard look at whether MCOs are really an essential part of the system. They're being touted as such. That's really not how we see it. We see a lot of interference with the claim processing functions far beyond just medical necessity. We see them coercing providers to change and not be the attending physician and refer things out when they have a long history, to interfere and try to direct the claim closure process or the medical treatment. We really think the doctors can handle this on their own without that additional layer. So that's really, for the benefit of our members, we have to make our position clear at some point in this process, and that's where we always stood. Thank you.
If I may, I think we're in agreement that processes can be improved. I think we also heard from Dr. Bowman, who does participate in managed care organizations, that they do serve a purpose, that there are some providers who are not necessarily following best practices, who may, I believe as Dr. Bowman said, enable some behavior and extend even work restrictions for unreasonable periods of time. So as much as the comment is that MCOs aren't necessary to the system, Dr. Bowman, who was the first to point out some of his concerns with managed care organizations, also did acknowledge the benefit to the system. And as the insurer, we too see the assistance that the managed care organizations bring to shepherding the worker through their course of treatment, to connecting them with medical specialists when appropriate and necessary, and ensuring that they are receiving the care that's needed. And so we see the value of those systems, and also maintaining an affordable system for employers as well, and ensuring workers are on that return to work path, which is part of their statutory mission to help workers get back to work.
I'll just say where we do agree with Keith, right? No, it's right. The pandemic has made sort of the access to care worse for everyone across the entire healthcare sector. And, work comp is just a interesting little slice of that one. So I agree with that, right? But the question is, what do we do after that statement? Do we just say, okay, well, it was just bad for everybody and that's it? Or are we trying to do something and change it, right? So I think our proposal is in the spirit of trying to change. Thank you.
Joy? If you're talking, Joy, I can't hear you.
Okay, can you hear me now?
Yes.
Okay. So thank you. Thank you so much. I've been it's a lot. I've been listening to everyone, speaking for the providers, speaking for the MCOs, and I agree with Keith, everything he said. We're here, to solve some issues for the providers and see if the insurance companies will work with us, and the issues we're having, trying to get hold of the insurance companies. That's our biggest problem right now, is trying to just work with the insurance companies. And there are not enough doctors out there who want to see work comp patients just because this is the reason. And like Keith said, we just need to, everyone just needs to work and solve this problem first. And then, when we're talking about MCOs, yes, I also agree. They create a lot of extra work, a lot of delays, a lot of paperwork for the providers. And one thing I don't understand from a provider point is when a claim is enrolled in an MCO, it is a lot of extra work. But the question is, do the providers get paid extra for those extra work and the MCO enrolled claims? Has anybody even questioned that? Versus the claims that are not enrolled in MCO. I think somebody really needs to look at that and see how much extra work is created for the providers and how much the treatments are delayed. So I just kind of, agree with everything Keith said. And I just, we just need a system that's going to work. And, trying to work with this claims adjusters and getting hold of insurance companies, just to get like simple things done. It's very difficult. And, and all these MCOs, we hear that they're, the panels are closed, and they have, they are saying that they have enough doctors, these other panels out there, the MCO panels. But then we hear it from the patients all the time, oh, I can't get in. They don't have enough doctors. So how can these MCOs say, oh, we have enough doctors when patients are calling us and they're getting upset because they can't find providers? So I just don't understand the system, but again, so I just kind of wanted to put it out there that we just, as providers, we just need something that's going to work for us and not create a lot of extra work, but so that we can still see patients out there. So I just, it has been, I think I'm looking at everything here from the meeting, everything is looking great. And I see that everyone, is trying to make this work, and then the work comp division and you guys, everyone, just trying to make this work. It's just really appreciate that you guys are, willing to help the providers to get this done. So I just want to say thank you. Thank you so much.
Thank you, Joy. Keith?
Just a real quick comment, and please someone correct me if I'm wrong, but I think the providers actually get paid less in MCO claims because the MCO gets a portion of the reimbursement. Please correct me if I'm wrong, but that's our understanding.
Joy, your hand's back up.
Yeah. Sorry. Yes, you are correct, Keith. Yes. So I just don't understand that. How can you, do extra work and get paid less?
So just so that I understand, this is something you are aware of and experiencing, and the question is really around why.
Yeah,
or how come,
I
rather than
why,
what's happening. Okay, that's helpful in just trying to make sure.
But it's just, I just don't understand the system with a lot of extra paperwork, and anyways, I don't know if anyone has ever said it, but I just wanted to put that out there.
Thank you for that. Okay, that feels like enough awkward pause. So if there are not any other questions around the SAFE specific presentation, which thank you both very much. That was very informative. I appreciate the updates. I see next steps for Kim and I to discuss. And I am gonna loop Terry, if you wouldn't mind. I just want to make sure, please, I need you to correct me if I'm wrong. In that the hope is to give from now until the next meeting for any additional feedback around the issues and proposed solutions from the perspective of like, wouldn't it be great if, or ideas that we've come up with just in conversations that we've had around solving some of these, in my opinion, like lower hanging fruit problems, as well as some of the addressing some of the large sort of systemic and operationalizing problems that we don't fully have an answer to, because obviously if we did, we'd already have the solution. And so the hope is we will give that space between now and the next meeting for any additional feedback, and then we will sort of take more time in the next meeting to go over the issues and their corresponding solutions. Is that, to your recollection, Terry, correct?
I'm going to unmute, but I understand I cause feedback when I do. So apologies, first of all. Yes, that is correct. And the other piece of it is we need to schedule the next meeting because this was to be our final meeting.
So the 9th of October.
Pardon?
I believe.
Yes.
Okay.
You and I and Kim
Oh,
talked about
yes,
it.
for the rest of the world, yes. For the other 48 people that might want to attend this meeting, I understand now.
Yes, so we were going to look at October 9th from 9 to 11 and our co-chairs, and we're good with that, but I just wanted to check with stakeholders or let them know that's the next meeting, if that works with everybody, because obviously we are not wrapped up yet. Okay, I'm going to mute again because the feedback is off.
Thank you. So it sounds like we will finalize the October 9th meeting. I have it as a hold in my calendar, so I just assumed it was done. And at that time would sort of be our final meeting for the ATC We'll review any additional feedback, sort of summarize the proposals and conversations that we had throughout this time, and essentially publicly finalize the document around what the issues we've heard and what the corresponding solutions would be. And then we move from there to do like final recommendations to the larger MLAC committee. Yes.
Exactly.
Aha, great. So those are our next steps. We do ask stakeholders to please send feedback through Terry, right? Is how we want to do it. Yep. For any follow-up questions as well, right? We formulated these based on what we understand. That template or that table is still missing any corresponding ORS or OARs that are relevant for the reasonability that like we couldn't crosswalk it just like this quickly. We do intend to have as much of a crosswalk as possible so that people can look at how things are operating now and what statutory language is in place, and then what and how it relates to the issue and proposed solution. That was just for me. I like a crosswalk, so that was a me request. And then as you get an opportunity to look through this table, areas in which your organization as stakeholders, if the issue and or proposed solution are relevant to you, and you would sort of take some of that on or have already done so, we would love to hear that as well, so we can look at what solutions are being implemented right now, and then what the accountability and enforcement looks like for those things, how we're going to continue to move that forward, what additional information that will hopefully drive some of the education from the division as far as what needs to happen as well. So please feel free to send feedback, questions, and claim any parts of solutions that you are already doing or want to do or feel are in your court to do. Kim, anything?
Get myself off mute. No, that sounds pretty good. So the only thing, this group, I mean, it's not like we're going to be voting on these. I mean, it's pretty much we're just compiling and putting them in the crosswalk, and then sending that forward to the larger MLAC committee.
In the end, co-chairs, we will write a recommendation letter to MLAC of what we're recommending. Okay. And then MLAC will make the final decision at the November meeting. Okay.
Thank you. You can tell some of us have not done this subcommittee thing before. Bless you, Terry, for all of your kind and gentle guidance. I do have space open for feedback. I know we've heard from several stakeholders today, either with proposals or follow-up questions. I don't believe we have anybody signed up for public comment. Is that correct?
We do not have anybody signed up for public comment. That is.
And it looks like it's you and Baba in that room, just hanging out. Great. So I'll give another 15-second awkward pause where we all stare at our little cubes and see if anyone has any additional information they'd like to provide, ask any questions, any final comments. Thais?
Hi, thank you. Sorry, I've got camera issues this morning. I just ask, as people are synthesizing responses for that meeting in October, keep in mind those employers, injured workers, et cetera, who do not have access to MCO enrollment right now. With the way the rules are set up, the contracts are set, there is a very large portion of Oregon injured workers, contracts, employers who, with the current system, cannot be enrolled in an MCO because there is no contract in place. So as we're looking at that access to care, provider networks, et cetera, what can we do to simplify and provide that access to everyone? Or what do we need to maybe change about how those enrollments are set up to be able to access MCOs for those groups who don't have access right now? Just to throw that out there as a bug for everyone.
Thank you, Thais. You came off mute, Kim. Just want to double check.
Yeah, I guess I need to, I guess, do some on my own work is like what determines, who gets the MCO and who doesn't, is that employer based? Is that how it, and so your employer decides?
Right now, it depends on how you are insured and who you are insured through, and whether that insurer, or if you're self-insured, if your company has a contract with the MCO or with an MCO in the first place, and then trickle down from there at the claim level. So if you look at, say, as an example, Safe as an insurer has contracts with the MCOs for the majority of their clients. They have a wide range of access for those injured workers to enroll them in the MCOs, to provide the provider panels, et cetera. If you look at, say, employers who have their insurance through Nationwide, because they're a small employer and they've got just whatever contract. If Nationwide Insurance does not have an MCO contract in Oregon, no one who works for an employer whose company insurance is at Nationwide has access to an MCO. And just as, so I manage a team of Oregon adjusters. We have about 1,100 open claims on my team right now. I would say out of that group, there are maybe 30, and that might be pushing it, claims that are enrolled in an MCO out of 1,100. Because
I thought you were going
of
to say the opposite.
No.
Oh.
So looking outside of the Oregon only insurance contracts, there is that wider piece with the way that the MCO contracts are set up, and being able to even access that in the first instance.
So those injured employees that don't have access to MCO, they still can receive care from a provider. Yeah. Okay.
But there are none of the controls in place that the MCOs do provide, as far as making sure you've got access to provider review for referrals, for treatment plans, those people at the MCOs who help coordinate appointments with contracted doctors' offices. So from the employee, the injured worker standpoint, if you're in an MCO, you have a little bit more access to someone to help you coordinate some of those appointments and referrals. But you're also limited to the list of providers who participate in the MCO. Those injured workers who are not enrolled in an MCO can go wherever they want, basically, as long as the provider is willing to work with the work comp system. But they don't have any of those other backup assistance with saying, hey, here's Dr. X who can schedule you. They have to basically do the legwork themselves. Because the processors are not allowed to direct their care. I cannot say, call Dr. Bowman, they'll schedule you. I can say, well, here are 4 offices that are nearby. You can give them a call and give it a try.
Thank you. Thank you for that additional explanation.
I see Keith's hand.
Thank you. I just have to say something on behalf of the injured workers and my clients I've represented for 22 years. Not a single one of them is seeking access to an MCO. What they see with MCO is the doctors have to submit the requests first to the MCO, who has their own process and limited guardrails and deadlines for making decisions. The request for treatment is often responded to with a question about prior appointments, need for additional chart notes, possible other procedures that could be done. That causes a delay. And this is before the question even gets to the insurer, whether they will cover what's actually being proposed. So we have an MCO appeal that has to happen if the MCO denies treatment. And then we have to go, if we're successful, perhaps in that appeal, they review it internally and review their own decision and then tell us whether they've changed it or not. We then have to appeal that decision before we can even take the question of causation over to the insurer. Workers do not want that. That is not helpful to the worker. That is what happens the vast majority of the time. Every once in a while, if we can't find a provider who will schedule, we do talk to the MCO about, who might be available. One of the things you heard over the summer is that these lists are not accurate. They look like there's a ton of MCO providers, but a lot of them have contingencies. They won't treat if it's a closed claim or if it's more than 6 months old or they have an attorney. We find that, and then, it's such a prevalent problem that we've had to develop a mechanism through rulemaking that allows a worker to request 3 providers who will actually schedule. And if one can't be provided, they're allowed to treat outside the MCO. Workers don't want all of that. It's axiomatic that the pool of providers outside an MCO is larger than the pool of providers in some sort of kind of exclusive arrangement where providers have to sign on to take a portion of their bill and give it to the MCO. I think all of us on this call that probably are hearing that are thinking, wow, I'd really sign up for that. In fact, I might not do workers' comp unless that were the deal, because I really need that support. I want to give that money to the MCO. I'm hearing it come out of my mouth. It just sounds absurd. I'm sorry, I can't put that any more delicately, but I feel an obligation to my clients, not only my organization, our members, but frankly, just to my clients in general to say why we're not fans of MCOs. It's not, we just want to oppose everything that industry likes. They're really harmful and cause delays in the process much more than they improve the quality of care, from my perspective and from my client's perspective. So I'll get off my soapbox now. I'm sorry for taking so much time in the meeting.
I appreciate your feedback, Keith. Giovanna? Maybe, Giovanna. There you are.
Yeah, thank you. Sorry, having a little trouble getting off mute today at home. I just wanted to thank everyone for their comments today and for the discussions and the materials that they've submitted. I think everyone is trying to solve a problem, and I do appreciate that. I did just want to echo some of Keith's comments and specifically respond to some comments that were made about good doctors and getting good doctors on the MCO list. I think that's really dangerous when we start talking about what a good doctor is, because I think we all have a different concept of that. To me, a good doctor is one who will treat an injured worker, provide them with all the care, talk to the attorneys and give them their opinion, and actually give the worker all that they need to get back to work so that they can be successful. I think some people, some stakeholders might think that the best doctors are ones that get people back to work immediately, who don't request a bunch of imaging, who don't request a bunch of, a bunch of rehab and other things. And so because we have different ideas of what a good doctor is, do we really want to expand the system of MCOs where the MCO gets to decide who a good doctor is according to them? And what we have seen in practice is the good doctors are the ones who will release the workers quickly, who will not request a lot of ancillary care, who will not continue to request rehab. And the doctors who do within the MCO get harassed and pushed out. And so we just have really big concerns. I do when I hear the word, we got to have good doctors in here, like who's making that decision? Right now, it's companies, and SAFE's asking for it to be SAFE who's allowed to make that decision on who a good doctor is, who's allowed in the system. I think we need to really look at the number of doctors who want to be in the MCO and are not allowed to be and are pushed out and are told they can't be. We really want a lot of doctors. Why are so many doctors that I talk to say, I applied for the MCO a million times and they won't let me in? I think we need to look at that before we talk about expanding this and allowing SAFE or private companies to continue to decide what a good doctor for workers' comp is and restrict workers to those doctors that they think are good. So those are the only things I really wanted to comment on. Thank you.
Thank you, Giovanna. Eva.
Yeah, thank you. I just, and I'll lower my hand here in a second when I can't do two things at once. I will say, Brad, we had a system without MCOs in the 1980s, and maybe I should have started my presentation with the 80s and not post-Mahonia, right? And pre-Mahonia, the 80s were a crisis in Oregon. We had the highest rates for employers in the country and the worst outcome for workers in the country as well. Both in a combination, right? The MCO system helps to manage costs. It helps to manage care. It is a fact of life. And listen, I appreciate sort of both Giovanna and Keith and them representing the clients. I mean, and it's wonderful. That's how the system works. When it becomes contentious or when there's a difference of opinions, that's when people will go and get a good attorney. And both of these great folks are great attorneys, right? And the system will litigate it through and there'll be an outcome. I appreciate Giovanna talking about good doctors. I have a very good doctor that I see in my personal life, right? But other than that, I can't comment on what a good doctor is at all. But I want to remind folks that we had a non-MCO system, and that was the 1980s, and this is why we're here. And yes, may not always work perfectly, but for the most part, it does. So thank you.
Paloma?
Thanks. I just couple things. One, concern about sort of making statements about what industry cares about and what they think is a good doctor. I mean, that is alarming to me. I think we need to take a step back and recognize that everyone is trying to make sure that the system works and it works to get workers to a point where they are healthy and able to work. But, you know, we've heard a lot, I think also today we've heard a lot about concerns about the burden of, you know, paperwork and compliance. And it feels to some of us from the employer community that may be a place where we could make some real improvements, that maybe there are models in other states to look at ways to ease that burden. Oftentimes it feels that our workers' comp system is still a little bit in the dark ages when it comes to paperwork, using technology, figuring out a way to make the system a bit more streamlined. We've had some conversations amongst ourselves about, you know, is there a way to create a portal that makes it easier for providers to navigate the system and also not to waste time on things that, you know, technology has moved for other ways in which they deal with insurance and that we've also heard like there are some requirements where you're still having to fax documents in. We should not ever be having that conversation in this day and age. So that's something that we would like to look at. I've just begun sort of digging into that, but you know, if there's a way that we can at least ease that burden at the front end, we'd certainly like to explore that as an option.
Thank you. Kim, anything you want to add?
No. Just, yeah, thank you for those additional comments. That really helps me, kind of helps enlighten me to, you know, the overreaching issues that we're talking about.
Right, just giving the obligatory 15 seconds. Are there any other comments, questions, feedback we can hear at this time? I do appreciate everybody's engagement and openness throughout this entire process. Lots of exceptional learning for me, lots of what I would consider as a healthcare provider, Low hanging fruit, I want to see fixed. I fully agree. Faxing, like why are we still faxing things? But I also understand some of the complexities around having employers, like the stakeholders, be able to communicate with one another, right? Software platforms are inherently proprietary. This isn't an easy fix, even though it sounds like it is. It's complex. I just want to reiterate that. And I do feel strongly that the engagement from all stakeholders is helpful in figuring out how to best move the system forward. Keeping in mind that the predominant concern that I have is to improve the experience of the injured worker, which is what system is for. So. Terry, I'm not going to make you come off mute because of the owl, but I lost your face too. I don't know where you went. I just want to double check if there's anything else, any housekeeping or administrative things we need to discuss before the.
No.
That is a chatty owl. Okay, well then with that, I will move. I don't know. I move to adjourn this meeting. There's two of us. I think we're both on the same page. As far as sort of ending the meeting here at just after 10:25. And again, thanking everyone and looking forward to seeing additional feedback, review additional questions as we move closer towards beginning final recommendations. All right, everybody, have a wonderful day. Thank you again.
Thank you. Thanks, Emily. Thanks, Terry.